Hello and welcome. I'm Dr. Robert Singer, Director of Neurovascular Therapeutics in the section of Neurosurgery at Dartmouth-Hitchcock Medical Center, and on behalf of Dr. Cliff Eskey and our entire team, I want to welcome you to this module on arteriovenous fistulas. It's our hope that the following information will be helpful to you in understanding your care. You'll have plenty of time to discuss questions during your virtual visit. What is an arteriovenous fistula? Arteriovenous fistulas can occur in multiple locations in the brain and spine. They represent an abnormal connection of the arterial and venous systems and are seen in adults and children. They can be congenital or acquired. Typical presentations include visual problems, bleeding, and hearing problems. This is an illustration of a carotid cavernous fistula, which is just one of many types of fistula. Again, the relationship between the artery and the vein is critical in fistula development. Essentially, the artery plugs directly into the vein, causing high blood flow into the venous system. This causes congestion in the brain and other tissue. Here is another example of a fistula, this one presenting oftentimes with hearing changes. Small arteries feed directly into a vein, which causes a pulsatile, almost pounding sensation with each heartbeat. Patients can become very bothered by the noise, and the poor blood flow out of the brain can cause stroke and other neurologic problems. AVFs can present in many different ways, and it usually depends on their location. They can present with hemorrhage, seizure, headache, progressive neurologic deficit, visual changes, hearing changes as we described, numbness, and weakness. This patient has a fistula behind his right eye. You can see the injection of the sclera, indicative of poor outflow from the orbit. The decision to treat AV fistulas is based on their location, risk of hemorrhage, age and health of the patient, risks of the procedure, and of course, patient preference. In most cases, patients are treated with embolization or catheter-based therapy. In some cases, open surgery is required. Radiosurgery, while being done on occasion, is very rarely offered. When being admitted for an embolization or catheter-based procedure for an AV fistula, most patients can expect to be admitted the morning of the procedure. This procedure time is usually around 4 hours. Patients can expect to go to the special care unit. They'll have CT or other imaging as necessary. Usually the hospitalization is overnight. In the case of AV fistulas, patients sometimes need to come back for another round of therapy, that being either more embolization or surgery, or in rare occasions, radiosurgery. When discharged, these plans will be made. When being admitted for surgery related to an arteriovenous fistula, patients can expect to be admitted the day of the procedure. Again, the time for surgery is usually around 4 hours. Oftentimes, intraoperative imaging such as an angiogram or ICG injection will be done to confirm the fistula has been obliterated. Special care unit monitoring is typical. The hospitalization is usually 3 to 5 days, and at discharge, patients are given a clinic appointment in 2 weeks. MRI at follow-up is usually 3 to 6 months. The risks of the procedures described include bleeding, infection, loss of neurologic function, stroke, hydrocephalus or poor circulation of the spinal fluid, and death. At Dartmouth-Hitchcock Medical Center, we have extensive experience in treating arteriovenous fistula. Our overall risk profile is very low and well within the accepted standards. Again, thank you for watching this video. We hope that it will help you in your understanding of AVFs and prepare you for your live visit, which will begin shortly. Please feel free to watch other modules and contact us with any questions or feedback.